Hello, happy Tuesday, happy Teach Me Tuesday. My name is Lisa Houston. I'm a NICU nurse and a NICU nurse educator here to give you another heart thing on our last Tuesday of February during Heart Month, Congenital Heart Awareness Month, Congenital Heart Awareness Week, and just overall our month that we talk about the heart. So we are going to talk about cardiogenic shock today, which is a big topic. Right? It is a big concept. It's a big diagnosis. It's not something that all of you are going to see in your NICUs. It's definitely going to be more for level 4 type of NICUs, or if you have a baby getting really sick. So that's kind of the ideal audience here. I think that this is so important to know. I've never covered this topic before. I had to dive in. I got to teach myself a few things. I'm going to tell you what those were because it's important that we all continue to learn and grow. And I want you to know and to be reassured that just because I have been a NICU nurse for a long time does not mean that I am an expert in all things. And one thing I think I'm really great about is being honest and transparent with all of you. And this was another thing that, yes, I know about it, I understand it, but I just dove back into it and really refamiliarized myself with this topic so that we could learn and grow together. So let's talk about what cardiogenic shock is. This is a life-threatening condition in which the heart is unable to pump enough blood to meet the body's needs. So what happens when we don't have enough blood? Our tissues lose their perfusion, they lose their oxygenation, and our organs start to fail. It causes organ dysfunction. This can be caused by a variety of things: heart defects, arrhythmias, myocarditis. I also don't want to leave out our old friend sepsis, right? Sepsis can cause things like this. If your baby's going into cardiogenic shock and you've had an echo, we then have to start looking for some of those reasons why. So that's going to be part of what we talk about. Early recognition is critical. Using the things that we have in our toolbox, such as an echo, to figure out exactly what's going on is going to be key. So let's talk about some of these causes. Let's go back to our congenital heart disease. You might recall during the second week of February, we talked about our cyanotic and acyanotic heart defects. So some of these heart defects that we discussed, something like aortic valve stenosis, can contribute to cardiogenic shock. Hypoplastic left heart, our coarctation of the aorta, pulmonary stenosis. There are a lot of those diseases where you see those words like stenosis, constriction, malfunction, coarctation, where there's a tightening, where our risk for cardiogenic shock is higher. So we need to keep our PDAs open, but if our PDA isn't open or if it's not functioning well enough, that's when the baby can get into trouble. Post-surgical, which also leads us to our babies that require surgery, right? So some of these babies, most of them are going to end up with surgery. Maybe we have another type of surgery going on, but babies that get into cardiogenic shock post-op usually is from a thing called myocardial stunning. Now, I have studied myocardial stunning. I know what this was. This is one of those things I needed a refresher on. So I wrote this down so I would read it to you in exact language of how I wanted it to be known. Myocardial stunning is a condition in which the heart muscle temporarily loses its ability to contract properly after a brief period of reduced blood flow or ischemia. So I want you to think about in this situation where maybe we have not had enough blood flow to the heart, and the heart is a muscle, and a muscle that doesn't have enough oxygen is not going to work well. So the heart is the exact same way. So that's going to increase this baby's risk for cardiogenic shock. Two other possible contributors to cardiogenic shock include arrhythmias, such as SVT or complete heart block can also do it. There's not enough time for the filling and the releasing and getting the blood out and perfusing the baby. In addition, you're going to have that conduction, right? The heart is a conduction system, and when it's disrupted, it can also change your cardiac output, which is going to contribute to your cardiogenic shock. Another thing to consider, myocarditis or cardiomyopathy, which causes that weak heart muscle. This can actually happen a lot in metabolic disorders. That's where I have seen it in genetic conditions. I have not personally seen it from a viral infection, but that can contribute to this. This is something that we talked about, if you remember, in 2020 with COVID and myocarditis as a possible side effect of that. This is what viruses can attack that muscle of the heart. So again, we're struggling to get that pressure to get that blood out to where it needs to go. So we're going to start having some signs and symptoms. Those are the 4 main causes of cardiogenic shock. So I want you to remember your cardiac defects, your arrhythmias, your post-surgical babies, and your babies with myocarditis or cardiomyopathy where their heart muscles are weakened. Essentially, what is really key in these situations is to think about how much blood the heart has to pump and how well the heart is pumping. And if either of those 2 things are affected, you're going to get into trouble with your baby. So what could that look like? What are these signs and symptoms going to be? You're going to have perfusion-related symptoms. That's your delayed capillary refill, cold extremities, which I feel like I have a great example of right now. My hands are absolutely freezing. So the cold extremities, weak or throaty pulses, cardiac symptoms, tachycardia, hypotension, a gallop rhythm. The heart is going to compensate. When you think about cardiac output, remember what our equation for cardiac output is: stroke volume times heart rate. So if our stroke volume is not enough and our cardiac output isn't doing well, the heart's going to beat faster. And just like any muscle, it's going to get tired, and then our heart is going to start to fail, and we're going to get into worsening shock. You could have metabolic signs, including lactic acidosis. On your blood gas, you might see a worsening base deficit. Your urine output's going to go down. Remember, the body remembers to perfuse the 3 most important organs, which is the heart, the lungs, and the brain. So it's going to start shunting blood away from the non-vital organs, such as your gut, your liver, your kidneys. If you see your urine output going down, you know your baby's in trouble. The respiratory symptoms you're going to see are tachypnea, increased work of breathing, pulmonary edema, especially as fluid continues to back up into the lungs over time. So what is our job to assess at the bedside? We want to be watching our blood pressure. We want to watch for hypotension with the narrow pulse pressure, doing those lactate. So whether you're doing bedside gases, maybe you have like an iStat machine that runs Chem8s, or you can add a lactate on, or your respiratory therapist run the blood gas, or you have to send it to the lab. Make sure you are getting those lactates on your gases. Some places those come automatically and others they don't. So something to think about. If you're having this mixed venous oxygen delivery, you're going to not have enough blood with oxygen going to the important vital organs. So that's really something you want to think about, and especially that if your venous output is really low, the tissues are taking all of the oxygen they need, and they're not really leaving any behind, right? There's not like a waste or a leftover amount. So that means the tissues are extracting more oxygen than usual due to this poor perfusion. You can imagine how that's not going to do well for the baby. And again, back to that urine output and the poor renal perfusion. I've said this many times, but if you notice that your urine output, and I'm not talking about a 1 diaper situation, right? Over a period of time, maybe your whole shift, your urine output's going down, you should be concerned. Even if it's something else going on with your baby, urine output is a great indicator of tissue perfusion. So what are we looking at when we are looking at our echoes, our advanced monitoring? We want to think about on our echo, we could see poor contractility, our ventricular dilation, or your ejection fraction. This idea of the ejection fraction is the most common thing I have seen cardiologists report out to the NICU staff in regards to what they see on an echo. And having this decreased ejection fraction really tells us that the baby's getting in a lot of trouble, and we have to help support what's going on with their heart and to help get them out of it sooner. We're going to be watching for skin temperature, we're watching our pulses, watching for our liver. Again, hepatomegaly is telling us that maybe the baby has congestive heart failure. Not great either. And then anytime your blood pressure is worsening, we know we're getting into a serious situation. So what medications are we going to use? What we need to go back to is when you think of the heart, you have to think of it like something that has this fluid that's coming in. It has all these parts. It has an electrocardio, system. It is a circuit. It is pumping this out, and then it has to pump it out against gravity out into the body. So the pumper has to be pumping frequently and strongly. If there's too much fluid to move through without enough pressure, you're going to start getting backup. Your shock's going to get worse. So we have to think about 2 sides of this coin. On one side, we have to improve the heart function. So that might be with dopamine, maybe with epinephrine. On the other side, we're going to look at the pressure and the ability of that left ventricle to pump. And that's when you're bringing in your afterload. This was another one that I went back and reviewed. And if you follow along in my Instagram today, I'm going to be posting some of the resources I use to help re-educate me on this. But afterload is the amount of pressure that the heart needs to exert to eject the blood during that ventricular contraction. So that's recorded as the systolic pressure of the heart. In afterload, if there's an increased resistance from the arteries, it means it has to work harder. And higher afterload is straining the heart. It's inhibiting its ability to pump effectively. So we talked about dopamine. We talked about epinephrine. Milrinone is going to come in as an opportunity to reduce our afterload. It's going to make the heart pump more efficiently. Dobutamine, we've talked a lot about, we did a whole thing on cardiac meds, right? The first week of February, we did a 2-part Teach Me Tuesday on cardiac meds. And we talked about dopamine and dobutamine and the different sides that they are parts of the equation that they're working on cardiac output. So maybe we need dobutamine for our contractility. Primarily, when I have seen a baby in cardiogenic shock, I see either dopamine or epinephrine. I don't typically see them together. And then with milrinone. And again, this is where your cardiologist and that kind of understanding of what's going on in the echo is going to come in. And it's so important to hear from them, hey, this is what I'm seeing. Maybe they're seeing poor contractility and they're like, let's get this baby on dobutamine. Maybe they're saying, hey, the afterload is really bad. Let's get the baby on milrinone. So that's where you're going to really pay attention to that. Other medications, we can use vasopressin for our blood pressure, PGE if we have that ductal dependent lesion, right? We've talked about this many times. If we need to keep that ductus arteriosus open, we want to be sure to have our PGE on. Fluid management. Again, we have to think about, are we going to give them too much fluid and that's going to make our pulmonary edema worse? If we're giving them a bunch of fluid and the baby's fluid overloaded and then the heart has to work harder, especially in the setting of kind of that pump and what's contributing to your afterload, we don't want to be overdoing it on their heart. So then not only may we be using fluid restriction, fluid management, but we could also be giving some diuretics such as Lasix. Lasix is probably the most likely in this situation. There are definitely other diuretics, but in a case of cardiogenic shock, we're probably using Lasix. So what are we going to do about this? We are going to have our intermediate interventions. So when you think about anything, like let's travel back to NRP. Maybe you're stable certified. If you ever took a stable course, I will never forget when I became a stable instructor, the stable instructor teaching the instructors. So like, I don't know, the big instructor, she would say over and over again, A, B, C's before S-T-A-B-L-E, right? We always have to manage our A's and B's and C's first. So what's going on with our airway? Do we need to do mechanical ventilation, especially if we're having worsening metabolic acidosis, if we're having worsening base deficits? What do we need to do here? We also need to optimize our oxygenation and our ventilation. We don't want to give too much oxygen. So airway, breathing, circulation. That's where inotropes are going to come in. We need to consider what are we going to do for them, which inotrope are we going to use, how are we going to best improve our blood pressure. And these are also babies, we talked about blood pressure during January with kind of our other assessments that we look at and what's considered a normal blood pressure. In this situation, we are probably not going to be looking for, if your patient is 34 weeks, a map of 34. We're probably looking for maps of 40 to 45. We want to really get that blood pressure in a stable place. And that's when you want to be paying very close attention to your orders, especially on the inotrope order, or if you're doing it in a nursing communication or in a conversation with your provider. What exactly is our goal for the blood pressure to make sure that we're getting there before we're doing any weaning? So remember your ABCs before we can do anything else in this situation. So again, the main things you're thinking about here, remember, too much oxygen can contribute to vasoconstriction, which we don't want any more constriction. Remember on the first slide when we talked about the congenital heart diseases, right? The stenoses, the constrictions. We don't want any more of that. We want to think about what's going to be our most effective inotrope. We want to take away the work of breathing, right? Anytime the baby has to work really hard to breathe, it's also putting pressure on their heart. So we need to take some of that away. Maybe that's in mechanical ventilation. And then watching for our early signs of decompensation so that we can escalate quickly. Again, if that's not working, a baby may end up on ECMO. Again, I am not an ECMO expert. I've actually never even seen ECMO. I've never worked somewhere where we did ECMO, and I've never seen it in person. So that is a very transparent answer from me. I would defer always to my experts on that. But you can understand how we could get to a place where we would need ECMO in the setting of our heart just having that failure. We may also need high frequency ventilation. Sometimes with traditional conventional ventilation, when you're doing this, right, you're really compressing on that heart during inhalation. So with small, more frequent breaths, we talked so much about high frequency ventilation last year. Got some great videos on that. I'm actually going to be revisiting that this year, so stay tuned. We also want to get early cardiology in there, and especially if you have a chronic CHD patient, having a plan for your surgical interventions. And then with your metabolic acidosis, what are we doing with our ventilation and our fluid balance? It's so important to remember how much ventilation plays into. We think metabolic acidosis and we think, oh, we need to, give them more, change their fluids or give them a medication for that. And when we think respiratory acidosis, it's always a ventilator change. But in situations with cardiogenic shock, you're going to be playing to both sides of that equation. So don't forget that, and don't discount the importance of what's going on with your ventilator. Neuroprotective care. So we want to prevent some of these hypoxic ischemic injuries that could be occurring due to the inadequate cerebral perfusion. If you are a unit that uses the NIRS, right, that goes one strip on the head, one strip kind of on the renal area, that's going to really tell you what's going on with your cerebral perfusion. I think that those machines are super helpful for watching trends and seeing what the blood flow is to those areas. If you don't have them, that's what we're managing with our hypotension and making sure our baby's adequately oxygenated. These babies often are going to be sedated to minimize the stress and the overstimulation. In the last 10 years, there's been a major shift in the sedation and the treatment of pain. And these are those situations where, unfortunately, we have to use it to kind of help the body recover. You're also going to see this in PPHN to really help the baby recover and to calmly kind of be present and allow the machines to work for them. We need to watch hypoglycemia and hyperglycemia. These are also can be side effects from the medications we're using. And then watch your neurological status. And if the baby's sedated, still doing neurochecks and making sure you're getting your baby moved. So this is stressful for parents, especially if it's an undiagnosed cardiac defect. So now we're catching things that we didn't know we had before. So you might have questions such as, why is my baby on these medications? What are the medications doing? You can refer back to our cardiac med lecture if you want. What does this mean for my baby's health long term? How can I be involved in my baby's care? Maybe your patient is still getting oral care. The parents could provide the oral care. They can be doing diaper changes, skin to skin whenever that is possible. I don't love the word stable here, but I do think in a place where we have able to get our lines in a good spot, our oxygenation in a good spot, and be improving in our blood gases. And then obviously participating in rounds and having an opportunity to ask questions. So to recap, cardiogenic shock is a life-threatening condition caused by the heart's inability to pump efficiently. Efficiency is what we're all about, leading to poor perfusion and organ dysfunction. We can see this in tachycardia, hypotension, metabolic acidosis, and poor urine output. I have seen a baby on high humidity on the beginning of my shift, at the end of my shift, intubated on 4 pressors because of this cardiogenic shock. His heart just started failing. It ended up being a metabolic condition. As I mentioned, I've seen that more than others, but just something to consider. We play a critical role in monitoring these trends and then titrating our medications, knowing what your parameters are, making sure you've had a conversation with your provider about that. We want to optimize our oxygen, balance our fluids, and then at the same time provide our parents with all the support they need as their baby is going through this life-threatening condition. So thank you for joining me for this higher level cardiac lecture. This is the 4th week, so we stepped it up a little bit with kind of a more advanced disease process with cardiogenic shock. I hope you learned something. I will tag my resources in Instagram if you want to follow along there, and there will be the tab for the cardiac defects, a highlight, that's what they're called. So be sure to check in there, and I will see you next Tuesday for another great Teach Me Tuesday.